right, let's get to it. It's the dialysis crisis, and our guests, Kwame Sarpong Asiedu and Dr. Elliot Tenkorang Annor. Okay, now I want to start with you, Dr. Annor, because we left off at a point yesterday. And, after you started to go into the solutions, which was very gratifying. You gave some suggestions to government on how to deal with this. And one of the things that really stuck with me was that you said we need to start focusing on wellness rather than illness. What did you mean by that?
All right. Thank you very much, Kojo, and good morning to your listeners. Yes, so what I meant was that generally, our healthcare system is basically curative in nature, in the sense that we wait for people to get sick and then they come in and we try to take care of them, which we are all beginning to realize that is expensive. And for that, from that point of view, we are preventing people from getting kidneys in the first place. I believe that's cheaper long run. And that is actually what I meant by that. Because of where I realized that most people sit aloof waiting for symptoms. And the difficulty with kidney disease is that by the time the symptoms get in, it is very late. So when we begin to know more about ourselves and begin to find out the state of our health, then if you get to know that, okay, your kidney function has reduced to, let's say, 70%, there are a lot of things we can do to prevent you from getting to the end stages. And that is, for me, where the focus should be on from the beginning. And then the few who will trickle into the end stages, then we will be able to push government to be able to support them.
So, number one, check your kidney health as often as you can. I think that's an important point. Very important point. And
normally, I liken it to, the mobile phone. I'm sure a lot of people can relate to it much better. Your mobile phone basically is, you charge it now. I'm not sure what could do yours is now, probably 90-something% with all the call, or 80. If you don't look on your phone to know it has gone to 80% or 70%, you will not know until it gets to that 15, 20, 10%, depending on the kind of phone that you use. Exactly how the kidney works. So can we look on our phone probably around 70% and make sure we do what we have to do to prevent it from getting to that 10% for us to require dialysis? I think that, for me, will be helpful as a nation.
Thank you for that. Now, Kwame, I want to bring you in on this whole wellness concept as well. And you actually, live and work in the UK. And it's a perfect example to use because the British government, spends taxpayers' money to run adverts on TV, to provide for parks and recreational facilities. And they almost make it mandatory for people to take time out of their working schedules to check on their wellness. The idea here being that they want to reduce the burden on their national health insurance scheme. How can Ghana tap into this sort of thinking?
Thanks, Kojo. You see, I like where I've been listening to Dr. Elliot Tenkorang since yesterday, and I like where he ended. And I want to use a quote that is used widely in wellness thinking. And it said that 20th century medicine was aimed at curing the sick.
Say that again.
20th century medicine was aimed at curing the sick. 21st century medicine is aimed at keeping the population healthy. So you see the paradigm shift. While in the 20th century, we were more interested in curing the sick. In the 21st century, the shift is to keep the population as healthy as possible. And what is meant by that? When you keep the population as healthy as possible, you increase what we call their quality adjusted health years, which basically means of the time they would spend, their life expectancy, how much of it would they be healthy and devoid from hospitalization, chronic diseases, and other things. And any population that has a high quality adjusted health years is generally a productive population. They have high GDPs, they have higher, tax to population ratios, and things like that. So countries like the UK, like Finland, like Norway, who've seen this, have said we do not need to allow the population to go in when they are unwell because once you push somebody into secondary, tertiary, or quaternary care, it costs the society more. So we need to keep them in primary care as much as possible. And how do you keep them in primary care? By identifying the diseases that affect them at an early stage. So, for example, like you rightly said, once your 40th birthday hits in the UK, you get a letter through your letterbox which says go for a health check, where everything is checked from your eyes, diabetes, hypertension, arthritis, everything. You are done cholesterol, you go for a health check. And subsequently, you are advised to periodically, for example, if you have a history of glaucoma in your family, you get a letter from your opticians once every year to say, come and get your eye checked and other things, because the cost of repairing someone's what you call optic nerve is much, much higher than the cost of preventing the optic nerve from getting damaged. The cost of blindness to the population is much, much higher than if the person can see and can work. So these are the mentalities that go on in societies that are positive when it comes to health and are looking at it. But for you to do those things, you need to be able to look at your disease burden trends. And I remember again, Dr. Okorachi said it yesterday, he was talking about the fact that renal disease is the forgotten chronic disease in our country.
Yeah.
And that is worrying because if you look at our disease burden trends from, let's say, 2009 to current, you realize that yes, still malaria is the leading cause of death in our country, but its contribution to our death toll has dropped by 64.3%. Right?
Yeah.
On the contrary, you see things like ischemic heart disease, which were 7 in 2009, are now 5th, and their contribution has increased by 3.5%. So when that is happening and you get one thing dropping and another thing increasing, that is when policymakers must start looking at how do we prevent ischemic heart disease from becoming a problem. The same thing can be said for renal disease. If we know, based on Dr. Franchin's research, that about 15,000 Ghanaians have to be on dialysis, but only 2,000 are on. The question is, how do we identify the missing 13,000? And to identify the missing 13,000, you need to ask yourself, what is the target of identifying the 13,000? Is it just identifying them and putting them on dialysis? Or saying that if we identify the 13,000, we put processes in place to identify people who are getting diminished renal function to about 70-80% and intervene early to prevent them from going on dialysis.
Yeah.
And these are the things that drive countries with a positive outlook to keeping their populations healthy and are missing from our approach to health. And I'll end on this note. Is it not a bit naive that you would put taxes on dialysis consumables, the machines and all that, and even products like epoetin and the medicines that they take routinely, when you are technically taxing only 2,000 people? How much is that contribution of those 2,000 people to our tax, envelope? Is it worth it? And these are the things that we need to ask ourselves and then plan positively towards keeping our people healthy. So that is the distinction that I wanted to make.
Yeah. I mean, it makes me think of our health-seeking habits as a people. And Dr. Tano, I mean, you deal with kidney patients, not just in your research, but in your daily work as well. What are your observations about our health-seeking habits? I mean, obviously, men are worse at it than women. That seems to be the case all around the world. But we have strange practices as well. For example, I know no other place in the world where someone can sit next to a stranger in a car, and then maybe the stranger will notice a funny rash on their skin and say, oh, my son had this. You go and buy this medicine from this person. When you go, tell them that I said you should come. And then the person will actually do it. A stranger has recommended medicine for them, and they will actually go and buy it and put it on their skin or swallow it or do whatever it is with it. And God knows what these things are doing to their kidneys. So much as we are, first of all, not doing the proper thing and going for the proper checkups and all that, we are also very trusting of unreliable or unconfirmed health advice. How do we combat that to ensure that we don't end up putting too much burden on our kidneys, Dr. Tano?
Stranger, example that you gave, I will give a practical scenario that actually happened in the hospital, where a young woman who actually was operating a shop, she was selling, and this gentleman passes by, of course, mentions all sort of conditions, which definitely will include one of the conditions this lady probably had. And, she bought the medication, and in 4 hours, she was admitted to Kwame Teaching Hospital.
Wow.
We got involved because there was something in the blood, which when the labs came, it was so low that she had so weak, and that was potassium. Now, one of the key things, with our body is that we need things to be normal. When people get kidney disease, their potassium actually goes up, because the body cannot clear it from the body.
Yeah.
So I actually got intrigued that what did this gentleman sell to this patient for the potassium to drop that quickly in such a period of time? Because I thought, okay, maybe there's something that can help, potassium to come down. But the key thing was that I asked her, do you know this gentleman? I said, Doc, I've never seen him before. Do you know where his shop is? I don't know where his shop is. If we want to locate him to find out what he gave to you, can we? He said no. And I was like, you were that trusting to put something in your mouth from somebody. You don't know the qualification. You don't know where he's coming from. You don't know where he stays. And indeed, when you even come to the hospital and we sometimes give you medications that are researched into, the ordinary Ghanaian will not even take it. That is the irony of the situation. So to answer your substantive one, our healthcare seeking behavior is so worrying. The gentleman you spoke to yesterday, you realized that most of them told you that, they were fine. And one kept on saying, I was active. To mean that if you are active, it means you are healthy.
Yeah.
Which is not true. The fact that you can go about your activities does not mean you are healthy. I have seen a lot of people rushed into Kwame, for instance, in their working gear. They were fine. They've always been fine until we realized that blood pressure is 240, 140. And he's developed a stroke or he's developed kidney disease and so on and so forth. We should get into the habit of knowing our numbers, I said yesterday. We need to know the numbers. You cannot walk around knowing your shoe size, knowing your waist size, your bra size, and not know your weight. And not know your sugar level, and not know your blood pressure, and not know your kidney function.
Right. Dr. Tano, if we can have you reposition yourself a little bit. The signal is a bit unsteady. So while Dr. Tano is repositioning himself, Kwame, I wonder if you have anything to weigh in on this issue of our health-seeking habits.
It's sad. You see, you need to also look at it from this point. You know that I normally like to drill down to the data. So we collect data on the average number of times a Ghanaian would visit a clinician in a year.
Yeah.
As at 2021, which is the latest data the Ministry of Health has, our patient per capita, which is the number of times on average a Ghanaian would visit a health practitioner, was 1.13, which means the average Ghanaian seeks healthcare once a year.
Wow.
Once a year. Yeah. This is official government data. Ordinarily, it should be about 4, which means you would seek healthcare once every quarter.
Every quarter.
Because you know that sometimes for the very young, for children, it might be once every 2 months or as they are growing because they go away and all. And then for the elderly, And then for teenagers, it may drop to maybe once a year or something like that because they are more robust. So when you put it all together, you need to have about 4 times a year. And 4 times a year becomes normal for anyone who goes past the age of 40 because you want to know your numbers. Maybe you check your blood pressure, your sugar every quarter to see how things are going. Ours is 1.13. We do not have any data that tells us how many people see quacks, priests, fetishes, and traditional medicine. We don't have any data on it. Yet, all you need to do is to go to any of our markets or to bar stops and you see all these things being sold. So I'd say there is a cultural dimension also to our health seeking behavior, and there is a regulatory dimension to it as well. Because our constitution and our laws, our public health, doesn't allow someone who's unwell to be taken to a church or to a shrine. But it happens in full glare of everybody. Sometimes you can even hear on some radio networks that some of these people are advertising openly that they can cure all manner of diseases. So it becomes very difficult when you are trying to solve a problem that has cultural underpinnings. Because the only way you can do it is to strengthen the regulatory and educational underpinnings. We seem not to be doing either. We are not educating people on the need to seek proactive healthcare, not to seek reactive. That I'm unwell and I'm going into hospital as against proactive. Oh, I'm going to check what my blood pressure is. We are not having that education. It's not part of our civic activities that we routinely do. The best you see is that what do you call it? Say a hospital, a church, or a Muslim mission organizing something like health checks or something because they are doing an activity, but we do not carry it through to the end. And for me, that is where we should start from. We should start from education and regulatory enforcement.
I want
if
to bring
we do that, then we can change the cultural thing.
Thanks for that. I want to bring back Dr. Tano. I think we've cleared up that line now. Dr. Tano, you were making an important point there.
Yeah, I'm sorry. I don't know where I lost you, but what I was trying to say is that we should know our numbers as individuals. Now, if we know our shoe size, if we know probably our bra size, our waist size, or whatever it is like, we should always know our numbers. Now, indeed, you cannot walk around not knowing what your weight is because you might not know that now for the past 1 week now you are gaining a lot of weight for which you need to do something about it. You don't check your blood pressure, you would not know that blood pressure is like 240 or 2 whatever until sometimes you are lucky and it gives you headache. Most of these chronic non-communicable diseases, unfortunately, they don't give symptoms. So if we are in a culture where somebody will tell you that, oh, doctor, I don't get sick. So I have never been, in fact, they get excited saying, I have never visited a facility before. And the first time you are seeing them, they have gotten something very chronic, which they are going to need some medication or some intervention that is super expensive. Which I believe that if we had seen them a year ago or 2 years ago, probably would have been able to change the dynamics. We need to be careful about our health. We need to know that without health as a country, we are nothing. We cannot do anything without our health. And a lot of people talk without even talking about the fact that they need their health to be able to do whatever they want to do. So if we are factoring all the things, our budgeting, how many of us put budgeting and say that, okay, I probably this my cholesterol, for instance, my blood pressure once a year or once in 6 months or whatever. No, we don't do that. No. Until you are told you have a condition that requires that you take medication, let's say every month, then you put it in your budget. Otherwise, as a young person, you go like, okay, I am fine. I never get checked and until one day you are carried to our facility, probably in your work gear. And the point is that sometimes when these things happen, we blame deity and we blame some old mother sitting somewhere for something. I keep saying that sometimes we make, the spirituality more like important. Of course, spirituality is important, but the point is, if you just check your blood, has come here and taking medication to get here. And indeed, for kidney disease, we ride on the diabetes, the hypertension. So when we check these things, we prevent ourselves from getting disease in the long run.
Right. If you just joined us, we're talking to Kwame Sarpong Asiedu. He's a research fellow on health with CDD. Dr. Elliot Tenkorang Annor is a senior lecturer and nephrologist at the Department of Medicine, School of Medicine and Dentistry, KNUST. We're talking, of course, about the dialysis crisis, and today we're looking at solutions. We started us off by talking about wellness, pursuing wellness rather than curing illness. Okay, so we've talked about our health-seeking habits as Ghanaians and how abysmal those habits are. When we come back, we'll start looking at how to turn things around. We'll get our two guests, Kwame Sarpong Asiedu and Dr. Tano, to actually address the government. We know they are listening. We will address them directly. We will tell them what they ought to do now that we are here because of what they failed to do. Stay with us. We're back after these.
Your morning radio.
Listen, let's get into our conversation. And Kwame Sarpong Asiedu and Dr. Elliot Tenkorang Annor are our guests. We're talking about the dialysis crisis. So before we took the break, we were talking about health-seeking habits and how dismal some of our habits are here in Ghana. I want us to address the elephant in the room, which is the economic factor. Proper health-seeking habits are expensive. If you're going to be eating fruits and vegetables, it's expensive. If you're going to go to the hospital once every quarter, it's expensive. So how do people of limited economic options properly follow health-seeking habits? Kwame.
You see, this goes back to why we went into the National Health Insurance Scheme at the outset. Because back then, we had accepted that health was expensive business. And no one can run away from that. So, to address this, we need to go back to the NHIS conversation. Because if you look at our economy, salaries are not going to go up anytime soon. And when you have a health system which is heavily dependent on importation, most of the equipment we are using are imported. Our medicines are heavily imported. Even the ones we manufacture in Ghana, the raw materials, equipment are heavily imported. So if we are saying that those two parameters are not going to change anytime soon, even though with AFTA and all that, the hope is that they are going to come, then the best bet is to look at the concept of universal health coverage, where one can seek health care and not be constrained by financial means at the point of use. And that is something that Ghana has already signed on to through the Sustainable Development Goals to achieve by 2030. So the question then becomes, is our National Health Insurance Scheme moving in line with our undertaking to obtain universal health coverage by 2030? That's the first thing. If it's not, then we need to start a conversation as to how we can get that to happen. We need to start a conversation about how we can recapitalize the National Health Insurance Scheme. I have always held the view that the capping of funding by this government going into the National Health Insurance Scheme is unhelpful to our health system. But I also agree that even if all the funds the National Health Insurance Scheme ought to receive based on the law were to go to them, it probably still would not be enough to cover most of the disease burden we have based on the trends we see going forward. And that is the other thing. We need to be able to understand our data and our health trends. If you listen to Dr. Tenkorang Annor, there's a lot of research is that there's a lot of numbers he's churning out. The question is who is listening. We often wait until the numbers and trends become real human beings before we start firefighting. That wouldn't work. And so we need a serious conversation around healthcare. I have already talked about education. We need an educated citizenry when it comes to health. and we need to enforce regulation. But I'll end it this way on this one, Kojo. Everything is within our capacity to do. I have looked at countries like Rwanda. I have looked at countries like Liberia. I've looked at countries like Sudan in a paper I presented. I've heard the likes of Dr. Kwame talk about countries like Kenya and Tanzania, whose health expenditure per capita is much lower than ours, but are able to provide dialysis to their citizens at a point that doesn't constrain them and doesn't tax them to their debt. These are things we have to look at. So it's about the honesty and the right conversations with the right people being at the table. That for me would be the starting point.
Okay, so Dr. Tano, I mean, the NHIA to some is an institution that has an uphill task. All of these taxes are being collected so that we can provide health insurance. But we are unable to provide health insurance. We're on our way back to cash and carry in many cases. We can't pay for so many of the things that are supposed to be covered. So people go to hospitals and are told day in, day out that the things that they are covered for are unavailable. And they end up having to go back into their pockets to pay in spite of health insurance. Do you see a way around this? Can health insurance take on something as costly as dialysis and properly pay for it?
Yeah, thank you, Kojo. I think my co-panel, rightly said that yes, if we look at how much is coming in and yes, how much, dialysis cost, as per the numbers that I put out there, then indeed that will be a lot for government, to deal with. And I think that is why I enjoyed the fact that we can reduce those numbers by all of those prevention, activities and, getting to know our health, so then the numbers that we can present to government might be something they can actually munch on. But nonetheless, it was also mentioned, I think government can show some commitment. I think it is okay for government to say, okay, we cannot take care of all of this, but maybe we can do this, we can do that, we can take this off, we can do that. I think that's some commitment on my part. However little it is might show that, okay, there is a start. And like I said, and compared to, other countries, chances are that we can look at what are they getting right. Probably, are they getting their national health in terms of the premium right? Is there something we can learn from these countries? What are the challenges they are facing? How can we make ours better under the circumstance? But the difficulty is that if it is nothing at all, then it becomes, tough, for us as healthcare professionals and for that matter, the patients who suffer this. So we agree that there is, a conversation that we should have on this issue to be able to understand where we can come from. Indeed, on the National Health Insurance Scheme, it was said that when you get, we talked about this yesterday, you get kidney injury acutely for a short period of time, it's supposed to take care of you. But then the healthcare providers will say when they send it, they don't get reimbursement. So now as it stands, you have to pay for it. So can we start from there that, okay, at least the acute is taken care of? Because the beauty of the acute is that if we're able to assume that it's acute, you get a couple of sessions of dialysis and pronto, you are back to normal in terms of your kidney function. You might not need it for the rest of your life. So it is an area we can look at, as we speak now. And indeed, the people who get acute kidney injury are sometimes pregnant women. Who in the course of pregnancy, their blood pressures will go up. And the moment the blood pressures go up, they develop something we call preeclampsia, and it affects their kidneys. No fault of theirs. They were not taking alcohol or drinking or smoking or whatever it is like. They just got pregnant. And in the course of the pregnancy, it's not like they didn't do something right. It is a condition that comes with pregnancy. But nonetheless, that poor woman should be able to live if there is a system to be able to take care of her. But if it is not, you speak to the family. Can they afford? They say they cannot afford. And sometimes you watch a pregnant woman die just because they can afford dialysis, which might not cost much because, like I said, about 3 sessions would have brought them back to normal. So we need to start from somewhere. We'll be happy to hear from government. We'll be happy to hear from major stakeholders. It's a crisis. How do we solve it?
How do we solve it? Well, that leads us very perfectly to the next thing that I would like us to do. And that is to speak directly to the president, to the health minister, to cabinet, to parliament, to all of those who stand between us and a viable solution to this dialysis crisis, I want us to advise them directly. Tell them specifically what they must do, step 1 to whatever the final step must be. How do we get out of this crisis? Kwame, I'll let you go first.
That's an interesting one. Okay, what I would say to the president and to our health leaders is that they should look at the data. A lot of the data we've been talking about, right through all the conversations on this renal fever, is data that is available in Ghana. They should look at the data. They should look at the trends. They should be advised by the experts who are researching the data. Because, like I said, it's untenable that we would put taxes on something that only 3,000 people are using and expect to get significant tax inflows from. It doesn't add up to me. They should also remember that when it comes to health decision making, they shouldn't devoid themselves of the thinking process, because sometimes they seek help out of the health system that most Ghanaians are using. What do I mean by that? For me, it's a very untenable that the thought of putting taxes on consumables for dialysis went through the Ministry of Health, the Finance Ministry, through Cabinet, went into a budget, went into Parliament, Health Select Committee, and passed without everyone knowing that the net effect was the cost was going to be transferred to the patient, and as a result, it was going to be unbearable and many were going to lose their lives, like Dr. Elliot Tenkorang was talking about watching a pregnant woman. Then finally, they should remember that these things demoralize the health worker. No health worker wants to see a patient they are managing die if the death was avoidable. This sort of demoralization is a leading driver of health worker migration from Ghana. They should remember that there is a teaching hospital in Ghana where one day they woke up and suddenly all their renal nurses had migrated to the UK. Has anyone gone to research why they left in a group? They should remember that it couldn't have just been the remuneration that they were getting. The work pressure could be a demoralizing factor. And these nurses are needed across the world. So we should not make life difficult for them and make their exit easy. That's how I end it.
Dr. Tano.
Yeah, thank you very much. So I think I will start off by entreating that government looks at how we can prevent, kidney disease. And in my opinion, most of these non-communicable diseases, they have similar linkage in terms of ensuring that, what people are eating and all of that are taken care of. And again, as healthcare providers, we also have a part to play to engage media more, so far as education is concerned. But when we need the required support, to be able to do that, I think that helps. When we prevent, we are able to do a lot more. And then two, I will suggest that, we are able to train healthcare providers in these peripheral hospitals that are seeing patients who probably might not have kidney disease as of then. But the point is that be able to know that, listen, you need to once a while check the kidney function. Like I mentioned yesterday, it's such a neglected, non-communicable disease. It's division among healthcare providers. And again, that leads us to worry. So a bit of task shifting as we train these healthcare providers to be able to pick some of these things. And like I mentioned earlier, third point, the government should take care of acute kidney injury. I think that is something that from tomorrow, I think it can be done. And I believe that we should do that to be able to save, people who get kidney disease acutely. And then again, of course, have the discussion with the Ghana Kidney Association and on how, they can help support people with chronic kidney disease. And of course, we've mentioned this as a fifth point, the taxes on health, consumables. That is what pushes the price up. So when the taxes are reduced, I think that will go a long way. And can we produce some of these, items locally? Again, if you're able to produce it, and of course you're not importing, then the dollar issue does not become a problem for it. Well, it might be dependent on, what the consumables that are needed for it. And then again, where I'll plead a lot with, there are a lot of herbal medications that are going out unchecked, and people are taking that is also harming their kidney. can we be a bit more forceful in ensuring that people know and take the right thing? Because now people that, it is approved by the FDA. As to whether it is really approved by the FDA, sometimes we cannot tell. And again, I'll push media also, because when they come to you to let our people hear it, maybe we may have to do the regular checks. And I think not long ago, there was a documentary where it looks like a lot of media houses don't do any checks, and then they just spew out things which our people listen to and end up taking, and running themselves into trouble. Then again, health workforce. Our people are leaving the country in terms of, the workforce. So if we don't have a lot of doctors, nurses, again, it's a specialized area. There are so few of us. One of the things I mentioned in that write-up, so few of us. And if the few of us are leaving because of all of these frustrations we have to meet or shoulder virtually every day, that keeps us worried, then chances are that there might not be anybody left in this country to take care of your kidneys, and the country's kidneys.
That is a very dismal picture indeed. We certainly hope it doesn't get to that point. Decisions must be made to stem the flow of talent out of our borders. Dr. Elliot Tenkorang Annor is a senior lecturer and nephrologist at the Department of Medicine at the School of Medicine and Dentistry, KNUST. Kwame Asiedu is a research fellow on health with the Center for Democratic Development. I want to thank you both so much for your time with us this morning.
Thank you.
All right. Well, that's where we put a pin in it. And this conversation, as you can imagine, it doesn't stop here. There's so much that needs to be done until the problems are actually solved, until the Kolibus of our country don't have to come out with, messages and backtracking and all of that, just because they have to make sure they can afford to provide the health care that people need to survive. Just so we don't find ourselves in embarrassing situations where we have to be calling around to friends and family to find money to keep us alive. Just so we don't do that. Let's make the right policy decisions so dialysis is no longer a crisis.